Okay. Good morning, everyone. Welcome to Journal Club on this special day, September 30th, 2022. It is the second year that we mark the National Day for Truth and Reconciliation. This is a day to mourn all that was lost as a result of Canada's residential school system. The children who never returned home, survivors, as well as their families and communities, the lost language and culture. On this day, we honor the resilience and strength of Indigenous communities across Canada in the face of seemingly insurmountable pain and trauma. On this day, we wear orange. Orange Shirt Day is an Indigenous-led grassroots commemorative action to raise awareness of the individual, family, and community intergenerational impacts of residential schools, and to promote the concept of every child matters. The orange shirt is a symbol of stripping away of culture, freedom, and self-esteem experienced by Indigenous children over generations. We take a moment to honor all that was lost. Thank you. We have two great presentations today. Our first speaker is Dr. Krisha Borromeo, Geriatric Medicine Fellow, speaking on Domperidone for hypotension in Parkinson's disease. Krisha, welcome to Journal Club. Please go ahead.
Hello, everyone. Good morning. Thank you for joining me. So I'm going to be presenting on Domperidone for hypotension and PD, a systematic review. I hope this will be quick. I have no conflict of interest. So why this question? I noticed that neurology started Domperidone for a patient with PD exhibiting severe orthostatic hypotension in TRI. So I was curious, as this was not usually common practice in the Philippines, to my knowledge. And I also don't have much experience reviewing systematic review, so I took this as an opportunity to learn as well. So I came about a research article on PubMed, and this was published in October 2017, and I'd like to thank Dr. Anna Gross, for her help in contacting Dr. Baki to access this article. So I used the CEBM guide on how to appraise systematic reviews. Based on the abstract of the article, the main objectives were to identify peer-reviewed studies with patients with Parkinson's disease. The interventions are Domperidone, and this will measure either the effect of Domperidone on blood pressure in patients with PD, or the adverse effects associated with Domperidone with its use in PD patients. So this actually squarely answers my PICO questions. Major bibliographic databases were used to search for relevant articles. So PubMed, Medline, Embase, and Scopus. The researchers used mesh terms for Domperidone and Parkinson's disease. So only these two terms were included in the search strategy. And despite these two terms just being used, the topic is very specific. So it's unlikely that a significant body of data would be missed, even if the authors did not use plain text wording. So another limit to the review article is that the studies were only limited to papers published in English. The criteria that were used to include the studies are: it should be a primary clinical research publication, it should involve patients with Parkinson's disease given Domperidone, and it should be available in full text, and either report the effect of Domperidone on BP in patients with Parkinson's disease, either with or without concomitant medications, or report the frequency or nature of adverse effects occurring due to Domperidone use in patients with PD. So excluded articles include studies wherein Domperidone was administered concurrently with another medication, as the reported side effects could not be solely attributed to Domperidone alone, and if the drug was analyzed in the context of gastric motility in the absence of Parkinson's disease. At the end of the search, the researchers found 22 articles. So from 1,935 publications, 432 were excluded as they were not in English. 1,310 publications were also excluded as they were not primary research papers or did not involve administration of domperidone to PD patients, and some were duplicates. And lots of other publications were also excluded as they did not meet inclusion criteria. So in the end, 22 did. 13 studies saw the effect of domperidone on BP, and 19 studies described the adverse effects of domperidone on these patients. So the most common dosages, as the dosages reported were very heterogeneous, the most common dosages reported were 10, 20, and 50 milligrams thrice a day. So the next 7 slides will tabulate the studies which were included in the systematic review describing efficacy and side effects. So I will first talk about studies which talk about domperidone's effect on blood pressure. So Schofer et al. Was the only study that assessed the efficacy of domperidone on blood pressure independent of new dopaminergic drugs. So it used a double-blind RCT crossover methodology to trial domperidone and fludrocortisone for orthostatic hypotension after non-pharmacologic therapy and a washout period. So due to adverse effects, 4 subjects withdrew, 3 from the from the dopamine group and 1 from the fludrocortisone group within 1 week of the first drug administration, and they did a per protocol analysis, which opens the questions or the potential for exaggerated point estimates, as the initial sample size was quite small at 17 only. So the orthostatic domain of the composite autonomic symptom scale, or COMPAS-OD, and the general clinic impression or CGI scales were used, and postural blood pressures were tested via PP apparatus or a tilt table test. And these were the primary outcome measures of this study. Although both medications, domperidone and fludrocortisone, improved scores, domperidone had a greater effect towards reducing BP drop on a tilt table test. So 3 studies done in the 1970s to 1980s assessed domperidone in the context of bromocriptine, another dopaminergic drug, used in a small group of patients. So the first 2 studies indicate that domperidone had a negative or actually no effect on BP, while the third study observed that the drug resulted in higher pressures if the patients were already hypertensive to begin with. So you can see where the mean blood pressures of these patients were at 150/87 for the domperidone group, and slightly lower for the group not receiving the drug at 143/77. So the next 5 studies done between 1970s to 2001 looked into domperidone use with apomorphine, a non-selective dopamine agonist and a strong emetic. So all of which yielded positive results. Arnold et al. Randomized patients to receive either ondansetron or dopamine with apomorphine, with the ondansetron group showing a significantly greater drop in blood pressure than the domperidone group. Corsini et al. Observed no hypotension in all 4 patients who received domperidone versus 2 out of 4 patients who received plain saline. The next 3 studies showed that co-administration increased baseline mean arterial blood pressure and heart rate, or attenuated orthostatic hypotension significantly versus the control group. So these were the studies made by Sigurðardóttir, which increased mean arterial blood pressure and heart rate, Merello and Polak. In the study by Schindler et al., treatment with domperidone before levodopa administration did not alter the degree of hypotension. But in Lang's study, domperidone prevented 2 out of 6 patients who received another dopaminergic agent from debilitating hypotension. So as you can see here, the study sizes were quite small. So most studies in the systematic review, which looked into adverse effects, reported cardiovascular abnormalities. The largest study out of the 4 was done in 2016. It was a retrospective case control study with 214,962,000 patients. The study determined that sudden cardiac death or ventricular tachycardia in the population was 3.28 per 1,000 person years on average, meaning 3.28 out of 1,000 PD patients will suddenly die or get ventricular tachycardia if we follow them for 1 year. So there is a non-statistically significant increase risk of 22% with domperidone use, increasing the incidence from 3.28 to 4 patients per 1,000 person years, with an absolute increased risk of 0.72 and a number needed to harm at 1,395. A different picture emerges for PD patients with pre-existing heart disease. The risk increases significantly from 238%, and the number needed to treat lowers from 1,395 to 952. And there was no relationship found between the duration of the drug use or dose with higher risk for patients receiving 30 milligrams of domperidone or less versus those more than 30 milligrams per day. The next study by Harandal et al. Found that only one person on domperidone in their cohort from 123 people receiving this drug had an atrial flutter, but a cause-effect relationship was not established. Cunnington reviewed the ECGs of 112 patients on domperidone. One-third of the patients had normal QT, half had prolonged QT of more than 450 to 500 milliseconds, and 16% had significantly prolonged QT more than 500 milliseconds. Blinding was quite unclear for this paper. Quinn et al. Was the only prospective study that reported on cardiac outcomes, but the benign findings are difficult to generalize with a sample size of 3. Van Dalen was a retrospective case control study of 5,000 patients assessed domperidone to all-cause mortality, and the drug was associated with a 2 times higher risk for mortality, the highest in the group taking 15 to 30 milligrams per day of domperidone. But it was difficult to generalize from the paper that mortality was just linked to domperidone, as the presence of orthostatic hypotension in PD has been linked to a diffuse malignant subtype, which might have baseline higher mortality rates. So the remaining reports include other adverse effects like tiredness and loss of appetite, restless leg syndrome, weight loss, nipple tenderness, and elevated serum prolactin. The limitations of these studies mainly include that the effect on BP was only assessed in the setting of a newly commenced dopaminergic agent with a small sample size, and the studies were predominantly retrospective or cross-sectional in nature. Most studies also did not describe how PD cases were defined, so the diagnostic criteria sometimes was mentioned, but most often not. So it is possible that other movement disorders that present similarly, like MSA, may have been included. Were the results similar from study to study? So obviously, no. The independent administration, as was found in the very first article, independent of other dopaminergic drugs, was the only one that clearly showed positive results on 2 scales. BP effect was mixed when you added a variety of other dopaminergic drugs given with domperidone, so bromocriptine, apomorphine, levodopa, and CQA showed mixed results, with apomorphine showing the most positive signals. And the largest retrospective study with 215,000 study participants in the retrospective study showed a statistically significant increase for harm for patients with pre-existing heart conditions, decreasing the number needed to harm from 1,300 to 952. So other smaller studies did not find this signal. So the studies were heterogeneous with varying methodologies. The bottom line for this research appraisal was that although the data is mixed, dopaminergic interventions with domperidone is worth a shot in PD patients with debilitating orthostatic hypotension, as I think was tried in the patient that I saw in the wards. Caution should be used for patients who have pre-existing cardiac conditions or patients with other medications known to prolong QT, such as antidepressants, antipsychotics, and certain antibiotics. And larger studies or randomized control trials are required to determine whether domperidone is effective independent of recent dopaminergic administration, especially in patients without cardiovascular disease. And we should measure QT interval prospectively in those studies. So this is the reference paper, and thank you, and I'm open to any questions from the audience.
Thank you, Krisha. That was wonderful. What an excellent review based on this meta-analysis, detailed and very clear. I will open it up to questions, either in the chat box or by raising your hand. I wonder, as people prepare their questions, Krisha, if I can ask you, going back to your case, what the evolution was.
Do you mean that what the patient?
Did you mention that you used domperidone on in your case?
Yes. So you wanted to know what the effect was? Okay, so it was effective in the patient. So the patient was tested in a hypertensive clinic, and she really did have standing supine hypertension with a resulting hypotensive picture upon standing, which led to dizziness and possible falls. So the patient was started on domperidone, 10 milligrams thrice a day, and in the wards, we did not see the orthostatic hypotension become problematic for her. So in her case, it was very effective.
And I should thank you. I should also add that often in these cases, a careful medication review for potentially inappropriate medications for those that may lower blood pressure is also very fruitful. And before adding a medication, the effort to attempt to wean or deprescribe medications that may be contributing is also very worthwhile. Shabir, your hand up.
Yes, thank you. Thanks for a great presentation, Krisha. Welcome to our journal club. I apologize if I missed this, but trying to get a sense of the magnitude of reduction in orthostatic hypotension with the domperidone versus, for example, the fludrocortisone in the trial or any of the other trials that were head-to-head. Can you give us a sense of the reduction or the greater reduction in orthostatic hypotension? In other words, if, let's say, the patient drops 30 points on placebo, and then they're put on fludrocortisone versus domperidone, how much is the drop reduced by domperidone compared to fludrocortisone? I didn't get a sense of that from the trials that you reviewed, because I have seen some patients on it. I'm not completely convinced that it works, but this systematic review was interesting.
Yeah, so that was, I think, the paper that I, hold on, so let me bring it up again. This one, the chauffeur paper. So this one addressed domperidone versus fludrocortisone. And if I remember correctly, it wasn't that great of a BP buffer either. So it wasn't more than 20 mmHg for both medications, but they did, I think it was in the range of 10 millimeters mercury. So it wasn't that big of a difference either from their study.
And of course, it's a very small sample size. So
and it's a small sample, yes. And 3
Okay.
patients also withdrew from the domperidone arm. So it's difficult to generalize from this study alone.
Yeah, I know some of the movement disorders doctors are quite strong advocates for it. Thank you.
Yeah.
Gary, go ahead.
Thank you very much for excellent presentation, Krisha. I guess it's always humbling when you do these kinds of reviews, I guess in essence to see how little evidence there is to really help you. It was a good presentation because number one, although you might not have explicitly said it, it appears to me that the possibility of bias in most of these studies was enormously high. And of course, the sample sizes were enormously low. And of course, a serious side effect like torsade, which is relatively infrequent, will not be something that you'll be able to assess in a small sample size study. So even balancing the potential for benefit, which I think is far from clear, against a very serious harm is, I'd suggest, probably impossible. Was there any effort, and maybe there's not enough good studies to do that, to actually try to do some type of sensitivity analysis where they try to eliminate studies with, lots of bias, or were not randomized, to at least try to narrow it down to studies that were of the highest quality and were randomized, to see if that gave any signal, or was that hard to do because they were so scarce?
That was very hard to do. So I was observing how many trials were included that actually explicitly stated that they were randomized within my one hand. So it's very difficult to generalize. And I was also surprised because apparently it's common practice to give domperidone, as you said, and that wasn't the case in the Philippines. So I just wanted to know what the evidence was behind it. And it seems like, as you said, the bias could largely weigh against confidently just doling this medication out to patients. Yeah.
Yeah, I just, as gray hairs, and I'm sure Barry can attest to this, when you don't have good evidence for treatments, Barry, I remember as an intern doing gastric lavage and all our GI bleeds, until finally that was appropriately studied to show that that was, not a very smart thing to do, and certainly not effective. So it's interesting because movement disorder specialists, it's a difficult problem to manage. You want to try something, but I think you did a great job of presenting this to make it clear to me that it's far from clear that there really is a benefit from this. And if you do it, of course, because of that serious potential side effect, you'd certainly want to very carefully monitor the patient's QT interval, for example, and as Dov said, make sure they're not on other QT prolonging medications, etc. But thank you for the presentation.
Thank you.
Thank you for the comments. Terumi, we have time for one more question.
Just a
Briefly.
comment.
Yep.
Thank you again for the presentation. It was great. I don't think that the domperidone we see in our Parkinson's patients is always for postural hypotension. In fact, I think it's more often to see if you can improve the efficacy of the L-DOPA in the first place. So I don't think we should assume it's for postural hypotension, because I know our expert uses it to try and improve the absorption.
Oh, I'm not sure. I haven't been in a movement disorder clinic, but domperidone does block the dopamine receptors peripherally. So I think yes, possibly. So instead of the levodopa, carbidopa being taken up by the peripheral receptors, by the peripheral dopaminergic receptors, I can see where that situation will cause most of the drug to cross the blood-brain barrier instead and target neurologic receptors. So possibly yes, but I'm not sure. I haven't talked to a movement specialist regarding how to use it for that purpose.
Thank you very much. In the interest of time, we will move on. Krisha, wonderful first presentation and great discussion as well. Thank you. We will move on to Dr. Corey Vincent, PGY5 Geriatric Medicine resident and a veteran at Journal Club, who will present on lithium use and the incidence of dementia. Thank you very much, Corey. Please go ahead.
Just going to share my slides. Everybody can see those okay?
Yep.
Okay, so thank you for the introduction. So the paper that I'll be presenting today is the association between lithium use and incidence of dementia and its subtypes, a retrospective cohort study. I do not have any disclosures to conflicts of interest to disclose, rather. In terms of what we'll go over today, so I'm going to review the proposed mechanism for cognitive protection from lithium. We'll review some prior research that looks at the potential utility of lithium in cognitive impairment, and then address the current study, which is the association between lithium use and incidence of dementia and its subtypes. We'll then go through a critical appraisal of these results and finish with a bottom line and implications for future research. So we know that dementia has a significant global impact, with 55 million people worldwide living with dementia and nearly 10 million new cases each year. We also know that dementia is a clinical syndrome, as we're all very, very well acquainted with, but that Alzheimer's dementia is felt to account for at least 60 to 70% of all cases. We're also all very acutely aware that there's no cure for dementia and that currently our pharmacological interventions are very limited. The majority of research is focused really on Alzheimer's disease, but even within Alzheimer's disease, we're limited to very few medications. And there's no pharmacological interventions that have been identified as a preventative or pre-disease state intervention for dementia, including no medications available for MCI in Canada. So with respect to the lack of interventions that are available, this has led researchers to explore the possible utility of medications that have been approved for other indications in the management of dementia or prevention. So that leads us to lithium, which is a medication that is used in psychiatric conditions, specifically bipolar disorder or unipolar depression that has been difficult to manage with other therapies. So despite its long history of use in the treatment of psychiatric conditions, lithium's mechanism of action is actually still not fully well understood. As it pertains to cognition, we know that lithium causes inhibition of IMP, which is an enzyme. The downstream effect of inhibiting this enzyme is that it increases autophagy, or the ability of our bodies to destroy abnormal cells. So this could be cells that have been mutated or damaged by beta amyloid, for example, in the case of Alzheimer's. We also know that lithium inhibits GSK3 beta, which is an enzyme important for for tau phosphorylation and for amyloid beta induced neurotoxicity. So inhibiting this enzyme would theoretically reduce tau phosphorylation and reduce beta amyloid neurotoxicity. It also inhibits AKT beta arrestin 2, which leads to a reduction in apoptosis of the neural cells. We also know that lithium is associated with an increased production of brain-derived natriuretic factor, as well as VEGF. So for all of these reasons, there's been increasing interest in the potential cognitive benefits of lithium. And what we've seen is in animal models, there have been studies showing that lithium can increase the hippocampal neurogenesis and improve cognition, and specifically in mouse models of Alzheimer's disease, so APP transgenic mice. They've also seen that in mouse models of infarction, that if lithium was given post-infarct, there is an ability to reduce the infarct volume, improve motor function, and improve cognitive impairments in comparison to those mice that received placebo. In humans, lithium has been associated with an increase in hippocampal gray matter volume in patients with bipolar disorder who were treated with lithium in comparison to patients with bipolar treated with valproic acid, but also in comparison to healthy controls. There have actually been some small RCTs that have looked at the use of lithium in the treatment of dementia, including a meta-analysis done in 2015. But as you can see, these are very, very small studies, and there's only 3 of them. So the total meta-analysis was actually conducted on only 199 participants total. They did find a positive effect such that lithium improved scores of cognitive function. There was a variety of tests that were used, including the MMSE and the ADAS-Cog. The studies also varied in terms of what the baseline population. So they would include patients, some of them included patients with MCI versus Alzheimer's disease, either early or moderate. They also included various doses of lithium. So the doses of lithium that have generally been studied in terms of management of dementia or improvement of cognition are generally subtherapeutic. So either targeting a level that's between 0.2 and 0.5, so below what you would expect for psychiatric conditions, or using, in the case of the Nunes et al. Paper, a microdose, which was a standard dose of 200 micrograms daily. There's also been one additional paper published since the time of this meta-analysis, which was again a very small scale RCT in patients with amnestic MCI, which did show a positive effect on both cognitive scores using the ADAS-Cog as well as functional outcomes using the CDR-SB. But again, limited by the small sample sizes, they haven't seen a significant increase in adverse events, but again, small sample sizes to be able to say anything with that regard. So because of the small nature of these RCTs, which may be at least in part due to the lack of drug company funding for a medication that's been on the market for so long and already has a number of indications, researchers are also looking to observational trials to evaluate the relationship between lithium and dementia. So in terms of the epidemiological evidence, there have been 3 studies done, one in the United States, one in the UK, and one in Japan, that have looked at trace amounts of lithium in drinking water and incidence of dementia. And all 3 found an inverse relationship such that higher levels of lithium in the drinking water was associated with a reduced incidence of dementia. Obviously, many possible confounders, but very interesting that it was seen at in 3 different studies at 3 different locations across the world. There have also been observational studies that have demonstrated an association between lithium use and reduced incidence of dementia, although these findings have been more mixed, with some studies actually observing the opposite, that lithium was associated with higher rates of dementia. One proposed explanation for the finding of increased rates of dementia with lithium is confounding by indication. So specifically that lithium is often or almost universally prescribed for bipolar depression or depression that has been difficult to treat with different medications. And we know that both bipolar depression as well as depression are themselves associated with an increased risk of dementia. In support of this hypothesis, in observational studies that have looked exclusively at a bipolar population, they find that lithium is protective in terms of lower rates of dementia in comparison to patients who are treated with other therapies. However, the impact of lithium on dementia prevalence outside the bipolar population remains to be fully understood. And so that was what led us to the purpose of the current trial. So the current study looked at the association between lithium use and incidence of dementia and its subtypes using a retrospective cohort design. They included individuals who had been referred to secondary mental health services through the Cambridgeshire and Peterborough NHS, CPFT from here on. And so this is an interesting database that uses the electronic clinical records from this mental health services and de-identifies them to create a research database. All patients are included unless they opt out, which they are given the ability to do, but it is quite a robust database of mental health services in this area. For their exposure, they looked at individuals who received lithium at least once during their study period. To identify this, they used natural language processing, which has been previously validated in other databases. And they identified people who either had a prescription for lithium or had had a lithium level done that was greater than 0.2 millimoles per liter. For their comparator group, they had individuals in the database who were not identified as having the exposure, so did not have either a prescription or a blood level greater than 0.2. And for their outcome, they looked at diagnosis of dementia as identified using an ICD-10 codes. The ICD-10 codes were input by the treating physicians as part of the EMR in terms of their other diagnoses. They also had a secondary question, which was to look at the difference in the relationship between the duration of lithium therapy and the outcome of dementia. And this was looked at using sub-analysis. So just in terms of some further details on population, so they included only individuals who were over the age of 50. They had to have been referred to the secondary mental health services in order to be included in this database. And they had to have had at least 1 year of follow-up to be included in the study. So they excluded patients who were not followed for at least 1 year in this database, and they excluded individuals who had a pre-existing diagnosis of either MCI or dementia, and this was done using ICD-10 codes. The outcome, as we mentioned on the last slide, was dementia using ICD-10 codes, so I've just listed the codes there. They did also do sub-analyses of the subtypes of dementia, and so they did that using the ICD-10 codes specifically for Alzheimer's disease or for vascular disease, respectively. So with respect to the study design, the study period was from January 2005 until December 2019. The index dates that were identified were different for the exposure and unexposed groups. So for the lithium group, the index date was identified as the date of first prescription of lithium or first lithium blood test. For the unexposed group, the index date was the date of registration in the health services database, or if they were already in the health services system on January 2005, that was used as the index date. The follow-up continued until either the patient had a final record in the mental health services database, and they died, or they had their first record of dementia. With respect to analysis, for the primary outcome of the association between lithium exposure and dementia, they used Cox proportional hazard models, covariating for sociodemographic variables, smoking status, co-prescription, and comorbidities. They also adjusted by inverse probability weights to account for treatment selection bias, which we'll talk a bit more about on the next slide. And for their secondary analysis of the impact of duration of lithium therapy, they used repeat Cox regression modeling. They did notably have one issue with missing data, specifically on their ethnicity data. And to get around this, they used multiple imputation with chained equations in order to maintain power while minimizing bias rather than excluding these individuals from the study. They also performed multiple additional sensitivity analyses, like a great many of them, which are included in the appendices. These were done post hoc in order to confirm the results of the study. So I just wanted to highlight the inverse probability weights, as it's not a statistical analysis that we always use. So this is a type of propensity score method that is used to reduce the impact of treatment bias in observational studies. And this is done because we know that lithium prescription is necessarily non-random. So clinicians think about which medication is going to be best for their patient, and there could be a lot of reasons that are potential confounders as to why they may or may not give a patient lithium. So with propensity scores, a propensity score is the subject's probability of receiving a specific treatment based on their observed covariates. And then this score can be used in a variety of ways. So one of these ways is with inverse probability weights. So in this strategy, they use weights based on the propensity score to create a synthetic sample in which the measured baseline variables are independent of the treatment assignment, to try and make it more similar to an RCT where every individual has an equal probability of being assigned to treatment or exposure or non-exposure group. The way that they do this is similar to in a survey sampling weight, where the samples are weighted so that they're representative of a specific population. And the specific way in which this is done is that subject's weight is equal to the inverse of the probability of receiving the treatment that they've actually received. The reason as mentioned for doing this is to remove systematic differences between the groups and allow it to be interpreted more in the fashion of an RCT. The major caveat with this method is the assumption of no unmeasured confounders. So we assume when we do this that we've measured every possible confounder that could impact treatment assignment. And that's specifically much more important than including every confounder that affects the outcome, because we're really dealing with treatment assignment in this case. And if we fail to include any confounder in the model, then it's likely that that's going to be unbalanced in your synthetic population. So this can be a major issue with any propensity score method, but it's also notably an issue with any longitudinal study. And so it's not necessarily made worse by using any of these methods. So the covariates that they identified for this study were age, sex, marital status, ethnicity, smoking status. They also included a number of co-prescriptions and comorbidities, which I've listed here. For the co-prescriptions and comorbidities, they were treated as binary time constant variables measured if present at any point in time during the study period up until 1 year prior to the end of follow-up. So that means that if you had a patient who was diagnosed with dementia, but 1.5 years prior, they had been given a prescription with an ACE inhibitor, then for the entire study duration, they were considered to have been on an ACE inhibitor. But if they were prescribed an ACE inhibitor maybe 2 months before the diagnosis of dementia, they were considered to have not been on an ACE inhibitor for the entire duration. With respect to cohort creation, I've included the flow diagram here. As you can see, they excluded individuals who had a baseline diagnosis or diagnosis within 1 year of entry to the cohort of MCI or dementia. They also excluded individuals with an age less than 50 years. And if they had a follow-up duration in the database of less than 1 year. So total, they had nearly 30,000 individuals included, but only about 550 who were exposed to lithium at some point during the trial. There were significant differences between the exposed and unexposed groups at baseline. Specifically, the lithium group was more likely to be married. They had differences in their ethnic backgrounds. They were more likely to be a current or former smoker. They were also more likely to have a number of comorbidities, including obviously bipolar depression or mania, but also diabetes or dyslipidemia. And they were also more likely to have had an exposure to antipsychotics. With respect to results, what they've presented here is the hazard ratios with the inverse probability weighted Cox regression, so that's already included in the analysis, and then further adjustment for covariates. So even the hazard ratio that is non-adjusted is adjusted in the sense that it was already using the IPW weights. So the hazard ratio demonstrates a significant difference between the exposed and unexposed groups, such that lithium had a decreased likelihood of dementia at any particular point in time, according to the hazard ratio. And this held true for both the Alzheimer's disease and vascular disease subgroups. Although, as you can see, there were wider confidence intervals for the Alzheimer's disease and vascular subgroups, indicating a less precise measure, probably because of a reduced sample size. When looking at lithium duration, we see that the hazard ratio remained significant for lithium duration of less than 1 year or more than 5 years. But in those intermediate durations, they had no significant effect. But as you can see, the confidence intervals for the intermediate durations were very wide, possibly indicating that there was insufficient power to detect an effect. So we'll move on to the critical appraisal. So the first question we ask ourselves is, are the results of this study valid? Did the study address a clearly focused issue? So yes, so they clearly defined their population, their exposure and outcome, and there was a clear a priori hypothesis about the expected effect of the exposure, specifically that lithium would reduce incidence of dementia or be associated with a reduction of incidence of dementia. Was the cohort recruited in an acceptable way? So I'd say mostly yes. There's a limitation with the database that was used in that it was a mental health database. So it may limit the generalizability to the general population at large. However, because lithium is a drug that is used primarily or predominantly for the treatment of bipolar disorder and almost exclusively only for psychiatric conditions, this is likely a reasonable location to find these patients. And the mental health services subgroup is probably a reasonable comparator group as well. Was the exposure measured to minimize bias? Yes. Was the exposure measured accurately? So I think yes. So the use of natural language processing has been used and validated in similar databases previously and is felt to be at least as good as manually entering coding into a system. There will be obviously people who are miscategorized, but to no more that of an extent than if we did this manually. They did use objective measures, so that was prescription or a lithium level of greater than 2, and they used 2 measures to identify exposure, which helped to minimize the miscategorization of patients as unexposed. Was the outcome accurately measured to minimize bias? Within the limits of the data set, yes. So they did use an objective measure, which was an ICD-10 code, and that was already directly input into the database. However, there is the possibility of undercoding, as this was done by physicians in their clinics. So it really depended on the motivation of any individual physician to enter the codes when a diagnosis popped up. It's likely, though, that any undercoding would be similar between the exposure and unexposed groups, because the reason for inputting this data into the system was clinical rather than for research purposes. And those who were doing it sort of without the knowledge that this study would be done in the future. Have the authors identified all important confounding factors? So I think for this, we have to say no. Benzodiazepines and Z drugs were not included despite being commonly prescribed in a psychiatric population. They also didn't include some other psychiatric conditions such as schizophrenia or anxiety, which could also be associated with cognitive decline. What's less clear is whether those conditions or medications would also be associated with the treatment allocation, which we discussed earlier is very important when we're talking about the inverse probability weights, but may have been more prudent to include these. Some other things that weren't included were anti-epileptic medications, opioids, psychoactive drugs, or prior diagnoses such as TBI or Down syndrome, which would have been important in terms of their relationship to the outcome, but arguably probably wouldn't have been as associated with the treatment allocation, so may have been reasonable to exclude. Have the confounding factors been accounted for in the design and analysis? So yes, so all of the ones that were identified by the authors were included in the inverse probability weighting, and they did do some additional sensitivity analysis, specifically for bipolar disorder, as well as some others in terms of further clarifying any impact of these potential confounders. Was the follow-up of the subjects complete? I think maybe to probably no. So the patients were followed, as you may recall, up until the point that they were no longer in the database because they had been discharged from mental health services or death or diagnosis of dementia. And it's really those patients who are then no longer followed in the mental health database that we don't know the outcomes. And it's possible that for those with short follow-up, maybe they were lost to follow-up because they had a developing dementia and didn't remember to go to their appointments, and we just truly don't know. So that may have led to some misallocation of patients as having dementia versus not, although again, probably similar between the exposed and unexposed groups. Was the follow-up of subjects long enough? So with the caveat of what I just said, I think probably yes. So the minimum duration of follow-up was 1 year. The average duration of follow-up was 4.3 and 4.8 years for exposed and unexposed groups, respectively. And they did actually do an additional sensitivity analysis where they excluded individuals who were followed for less than 2 years and found that they had the same results, despite having a smaller sample size. And we know from RCT studies looking at the effects of lithium, although there's few and there are small sample sizes, it seems that it takes about 3 months of lithium exposure to start seeing a benefit. So they likely had a long enough duration in order to capture that. So what are the results? So we've already kind of gone through this, but the lithium exposure was associated with a lower risk of dementia with a hazard ratio, adjusted hazard ratio of 0.56 and a confidence interval of 0.4 to 0.78. The subtypes were also had a significant, were associated with a lower risk of dementia. And with respect to duration, there is a significantly lower risk of dementia with the short-term and the long-term exposure, but not with the intermediate durations. How precise are the results? So for the primary outcome, the precision was reasonable in terms of the confidence interval, but it was much wider for the subtypes and particularly for the durations of therapy, suggesting that it may have been underpowered to look at this effect. And then do you believe the results? So I'm going to cop out and say partly. So I think that there's enough, there's a significant amount of other epidemiological data looking at the relationship between lithium use and Alzheimer's disease in this mental health population or in patients who have bipolar disorder to say that there likely is a reduced risk of Alzheimer's disease with lithium exposure in this population. And there's also the additional biological plausibility that lends itself to this. So I think from that perspective, we have some evidence to say that we can trust these findings. When it comes to the vascular disease portion of this, this is the first longitudinal study to evaluate a relationship between vascular disease and lithium use. And there is some biological plausibility studies, which we talked about earlier, to support this, but because it is the first study and it's in such a specific population, I think further research is needed. And even with respect to Alzheimer's disease, again, further research would be needed to say that lithium has this effect outside of a population who are being treated for their psychiatric conditions. So will the results help locally? Can the results be applied to the local population? No. The purpose, so this was done in a mental health database. And given that this and all other epidemiological studies on the effect of lithium on risk of dementia are necessarily conducted in patients who have mental health disorders, we really can't generalize those results to the general population because these individuals are going to necessarily have differences from our general population. There is some support theoretically from the drinking water studies that maybe these effects do generalize to a general population. And the RCTs that were conducted were also done in patients who had dementia, but did not have other mental health disorders. So there's some suggestion of that, but from this study itself, then no, we can't apply to our local population. Do the results fit with other available evidence? So we've kind of already talked about this, but yes, there's been some variability in the literature, but the majority of the epidemiological studies have shown a reduction of dementia incidence in patients who are exposed to lithium, and differences may be the result of confounding by indication or sample size or covariates. And what are the implications of this study for future practice? So I think this is the most unclear. So the proposed purpose of this study was to evaluate lithium as a possible preventative strategy for dementia. However, given the numerous side effects and monitoring parameters for lithium, it would really not be a good preventative measure for our general population. Even if we're thinking about targeting patients who are at higher risk, the risk benefit of giving so many patients lithium would be too high. And there's not enough evidence to suggest that even at the microdoses that it would be safe. The current study was not developed to evaluate a therapeutic effect of lithium in patients who have MCI or dementia. But this, I think, is a possible role for lithium in the future, particularly in the area of dementia, or sorry, in MCI, where maybe there then could be a role for preventing development of dementia. Finally, I guess the other possible implication for this study would be that for individuals who have bipolar disorder, you could argue that the use of lithium may be beneficial over other mood stabilizers, given its effects on cognition. So with respect to the bottom line, so in a retrospective cohort study using clinically derived mental health database, lithium exposure was associated with a reduction in risk of developing dementia. The study population limits its generalizability as it's a mental health oriented database. RCT level evidence would be needed to evaluate the causative effect in the prevention of dementia. However, as we mentioned, the practical utility of using lithium to prevent dementia is just simply not there, given its side effects and need for monitoring. Lithium use over other mood stabilizers may be warranted for patients who already have an indication, such as bipolar disorder, because of its increased, because of its possible protective effects, as well as their already increased risk of cognitive impairment. And future research is needed to the potential benefit of lithium as a possible therapeutic option for dementia or preventative measure for development of dementia in patients with MCI. So these are my references. Are there any questions?
Thank you, Corey. Outstanding. What a fabulous presentation. Thank you. Barry's been waiting very patiently with his hand up. Go ahead, Barry.
I have to admit that it was a busy week, so I only scanned the article beforehand. But you know, the old saying that death is a great way to cut down on expenses. Death is a great way to cut down on dementia. And I couldn't really figure out whether, because we know from previous data that people with bipolar disorder do die younger. So I couldn't figure out the exact reason for that. The other thing that I worry about is that with people with psychotic disorders often have functional impairment. My personal experience over many years is that it's sometimes difficult to determine whether we're dealing with the psychotic disorder or dementia, and that sometimes delays the diagnosis of dementia. And that's a hard thing to correct for in an ICD database. And the other, just one comment, when John Werrett was doing the Canadian Brain Bank before it ran out of money, Alzheimer's was not the commonest cause of dementia. It was mixed vascular plus Alzheimer's. By far was the most common thing. So whenever you see a pure distinction between that and any study based without autopsy, take it with a grain of salt.
Yeah, and these were based on ICD-10 codes, so like even more prone, and they weren't putting them in there for research, so really not a lot of motivation to be very specific about the type of the type of dementia that the patient was diagnosed with. With the respect to the point about death, like being a prevention for dementia, they did do a sub-analysis. Now, the details of this I'm not recollecting quite as well as I maybe should, but they did try and address that in one of their sub-analyses and found that it didn't significantly affect their outcomes. But I mean, it's going to be a confounder for you can't avoid that for sure.
My first thought looking at the table was that I should take up smoking because that group had less dementia because they smoked more. And I should have corrected for the lithium exposure with the analysis rather than for the smoking exposure.
Right.
Great, thank you. Gary, go ahead.
I'd just like to begin by saying, Corey, that was an absolutely exceptional presentation. You know, I learned so much from Barry, starting from residency throughout my career. So I agree with him. I think, you know, the issue as to whether people who have the types of diagnosis that are given lithium are as likely to be diagnosed with dementia as people with other types of mental health disorders that maybe aren't as severe, may be a problem. The other thing that I wonder about is Zainer Ishmael, you know, has coined the term mild behavioral impairment as a like MCI as a preceding dementia, as to whether it's more likely that people in the group that didn't get lithium may be more likely to have types of sort of mental health problems that may actually presage dementia rather than people who have major depressive disorders or major bipolar disorders that, yes, they are risk factors for dementia, but maybe not in the same way. And I'll just find my last comment, as many who know me have heard before, is there have been numerous examples where major large observational studies did not pan out when the treatments shown to be beneficial in those studies were studied in randomized trials. So I'll ask the same question here. When you look at your table of baseline characteristics and the two groups are so dramatically different in so many ways, can you ever correct for that statistically in a way that you can make some type of conclusion that is likely to be accurate? I don't know the answer to that, but it's quite clear that these populations are quite different. And kudos to the authors using the propensity type approach, etc. But the question is, can you ever correct sufficiently when you're comparing apples and oranges? I don't know the answer.
Yeah, I completely agree. These are very, very different groups. And even just the one factor of almost necessarily having a diagnosis of bipolar disorder being a reason for treatment, and then everybody who's not on lithium, some of them will have bipolar disorder, but most of them will not, in and of itself is really hard to control for, because that's essentially linked to your exposure. So, and the authors did try and get around that again with sub-analyses, but I think it's not, yeah, to your point, can you ever really fully do that? I don't know that you can.
Great presentation, Corey.
Yes.
Absolutely wonderful. Two wonderful presentations today. I want to thank our community colleagues who join our journal club very much for participating. Please do remember to complete the evaluations that were sent by email about 5 minutes ago. And we look forward to seeing everyone again at the end of October for our next journal club. Thank you, Krisha and Corey, for a wonderful way to start Friday morning.
Incredible trainees.
Yes. And I'm getting